You won't hear frontline science from me, but I will rather reinstate what you usually and routinely see pre- and post-operatively in these patients. This is a very simplistic way to sort of categorize congenital heart disease and its affecting, and how does it affect the respiratory system. So you may have a congenital heart disease which does not affect at all a normally functioning respiratory system, in which place you are in the ideal situation to operate on. You may have a congenital heart disease that affects a normal anatomically respiratory system by various ways. You may have a congenital heart disease with a coexisting abnormality of the respiratory system, or a complex congenital heart disease within a syndrome. How congenital heart disease affects a normal respiratory system? First, by airway compression. Second, by increased lung perfusion, which leads to decreased compliance, interstitial pulmonary edema, and pressure on bronchi and bronchioles from the engorged vessels within the lung parenchyma. We should bear it in mind, especially in situations where blood flow in the pulmonary circulation is very increased, because it affects the cartilage, it affects the bronchi and the bronchioles, it predisposes to atelectasis and infection, and it causes a vicious circle. And all congenital heart diseases, or most of them, are at increased risk for pulmonary infections. Anatomic airway compression may first come from left atrial dilatation, which causes widening of the carina and bronchial compression, especially of the left mainstem bronchus, and you can see it in various congenital heart lesions. That may lead to left lower lobe atelectasis, infection, and in the long-term bronchiectasis. Anatomic airway compression by large vessels is quite common, and there is a whole list of abnormalities that can lead to that. And first of all, we know that some of these lesions are described as vascular rings or slings. They account for 1 to 1.5% of congenital heart diseases. They cause tracheal or bronchial compression. They present with a variety of symptoms, and occasionally they are revealed during a respiratory infection where the diagnosis is made for the first time. The most common is vascular ring by double aortic arch and its variants, and it has a very respiratory symptomatology, and it may be undiagnosed until adulthood. Pulmonary artery sling is caused by an aberrant pulmonary artery, which courses between the trachea and the esophagus. It causes compression at the level of the carina. It is characterized by an early presentation in early life and respiratory symptoms which are more severe than in other vascular rings. But you have to bear in mind that this abnormality is very frequently accompanied by complete tracheal rings and tracheal narrowing, which may progress down to bronchial narrowing. And the most severe distress is caused by the primary tracheal narrowing, not by the sling itself. On the left side, you can see characteristic pictures of two patients we have encountered here. The first one is how do you see bronchoscopically the complete tracheal rings, which lead to a very narrow end of the trachea before the carina. In the lower part, you see the first bronchoscopy preoperatively of a patient with pulmonary artery sling and complete tracheal rings. The intraoperative correction of the abnormality with a slight tracheoplasty, and the postoperative picture. The next is the aberrant innominate artery, which causes mild anterior compression in the mid-trachea. It rarely causes symptoms, but if it does, you may have near miss or death spells, as they call these cyanotic episodes that may lead to cardiorespiratory arrest, as it happened on this patient, in which you see the two bronchoscopic pictures. The CT scan of this patient showed a very mild tracheal compression, but bronchoscopically you see what happens in this patient, and concomitant tracheomalacia led to 2 cardiorespiratory arrests. Patient was kind of lucky enough and went on to the operating room. Absence of pulmonary valve caused significant enlargement of pulmonary artery and compression of central airways. And as I mentioned earlier, dilated distal pulmonary arteries surround and compress the inner lung branches and the bronchial tree, which leads to other development of cartilaginous apparatus causing the emphysema and is accompanied by high mortality. I come to another issue, which is congenital heart disease and lung hypoplasia. Scimitar syndrome is characteristically a typical example with hypoplastic right lung, and the severity of the illness depends first on the degree of hypoplasia of the lung and second by the presence of obstruction of the pulmonary veins. Another situation is congenital diaphragmatic hernia with concomitant ipsilateral hypoplastic lung, and when you have concomitant congenital heart defects, you have to bear in mind that this patient postoperatively will have problems with oxygenation, ventilation. Another entity is when you have congenital heart disease and pulmonary hypertension accompanied by lung dysplasia. There are many common congenital heart lesions associated with increased pulmonary blood flow and the pulmonary hypertension. But when pulmonary hypertension is presenting very early in life and is disproportionately elevated for the underlying lesion, think of lung dysplasia. Alveolar capillary dysplasia with misalignment of the pulmonary veins is an entity, a rare entity, which is characterized by decreased density and normal positioning of the pulmonary capillaries, thickening and hypertrophy of the small pulmonary arterioles, immature lobular development, lymphangiectasis, muscularization of distal arterioles, and misalignment of the pulmonary veins. You can see in this picture an artery, a vein, and a bronchiole running in parallel, as it was not supposed to happen. This end is characterized by early neonatal presentation with cyanosis, severe respiratory distress, intractable to treatment, and severe pulmonary hypertension. But there is a late presentation which may be manifested after 4 to 6 months of life. There are other congenital anomalies in some of these patients, and at least 50% have a mutation, the FOXF1 gene at chromosome 16. And according to the case reports, more than 200 have been published so far. More than 90% of these disorders are diagnosed post-mortem. Here is my personal cohort of patients with alveolar capillary dysplasia, with or without misalignment of pulmonary veins. The first patient was operated on at the Boston Children's Hospital for a very huge PDA, and the lung biopsy and the autopsy confirmed the alveolar capillary dysplasia. The 5th and the 6th patients were treated in this hospital, and they both died, but both were operated on. And all the other patients had congenital heart disease with left to right shunt, PDA, ASD, or VSD. The patient number 4 was evaluated for pulmonary hypertension by only clinically at the Great Ormond Street Hospital and died at his house. And I show here Dr. Claire Langston's comment on his biopsy. Claire Langston is the world's most famous pathologist of lung pathology in children. And he says that this is alveolar capillary dysplasia without vein misalignment and with growth arrest usually at the later canalicular stage. So these lungs have not been developed, they are grossly malformed. And they may or may not have associated pulmonary hypertension, but I do not know of any infant with this disorder who improved. So, in preoperative assessment of the congenital heart disease patient, we have to bear in mind that we must recognize other comorbidities with diagnostic studies, CT, MRI, bronchoscopy, or genetic testing. We have to manage these comorbidities preoperatively. We have to plan additional procedures at the same time, like slide tracheoplasty in patients who have a complete tracheal rings and tracheal narrowing. And we have to bear in mind that if we open the chest and we have doubts about the presence of lung dysplasia, we have to take a lung biopsy. Going to postoperative effects on respiratory system, bypass and reperfusion can cause abnormal pulmonary mechanisms which are multifactorial. Cardiopulmonary bypass causes systemic inflammatory response, ischemic lung injury, perfusion injury, damage to type 2 alveolar pneumocytes, and increased microvascular permeability. In this multicenter study, any postoperative complication account up to 35% in congenital heart disease operated patients. And you can see some examples. I will go on quickly to extubation failure due to diaphragmatic paralysis. The intraoperative injury to the phrenic nerve, we use the left side, may be due to direct trauma or thermal injury. The diagnosis confirmed by fluoroscopy and bedside ultrasonography, and the treatment is by diaphragmatic plication if there is increased work of breathing and failure to win from mechanical ventilation. Trauma to the cardiolaryngeal nerve is mostly transient. It causes unilateral vocal cord paralysis with hoarse voice and weak cry. Airway protection is potentially compromised, and we may see signs of aspiration when patient is both fed. And if aspiration does occur, a multidisciplinary approach with a speech and language therapist and placement of NG or gastrostomy tube may be required. Pleural and pericardial effusions are quite common due to elevated central venous pressure, which causes a transuddative pleural effusion, or increased microvascular permeability, which may lead to exudative pleural effusion accompanied by Kylie. And severe case can compromise cardiopulmonary function and may lengthen the ICU and hospital stay. Pneumothorax due to surgical trauma or positive pressure ventilation-induced alveolar rupture is managed by prophylactic percutaneous injection from catheters in the pleural space. Chylothorax, another not uncommon complication. There are patients who are at high risk because have high risk comorbidities like age less than 1 year, single ventricle physiology, extracardial anomalies, longer cardiopulmonary bypass time, or thrombosis associated with an upper extremity central venous catheter. In the postoperative period, traumatic disruption of the thoracic duct and thoracic duct occlusion due to venous thrombosis or external compression may lead to chylothorax, which leads to significant loss of plasma proteins, lymphocytes, lipids, and lymphopenia, immunologic dysfunction, coagulation, abnormality, malnutrition. And that requires also an integrated and interdisciplinary approach for its management. Last but not least is cast bronchitis, which is an abnormality of lymphatic drainage that can be seen after Fontan procedure, Glenn, tetralogy of alveolar repair, or arterial switch, and also rarely in other congenital heart disorders. The time of presentation may vary widely. It may be 2 months or several years after the procedure. And the treatment is by bronchoscopy and extraction of these large casts, if they are present, and by use of various kinds of medications for prevention of it. In conclusion, postoperative care principles, you have to optimize oxygen and substrate delivery to the myocardium and key organs, minimize oxygen demands, address other acquired comorbidities, perform diagnostic studies, and have a multidisciplinary approach and management. Thank you for your attention.